18-year-old patient. Complaints: high-grade fever, severe headache, neck pain, vomiting. Symptoms started 24 hours ago. On examination, temperature elevated, patient irritable. Neck movement painful. Light sensitivity present. No history of trauma. Clinical suspicion: central nervous system infection. मैं हूं डॉक्टर अभिषेक और अब हम स्टेप बाय स्टेप समझेंगे कि मेनिंगाइटिस क्या होता है और कैसे मैनेज करते हैं। Meningitis. Meningitis is inflammation of the meninges, the protective coverings of the brain and spinal cord. Normally, meninges protect the brain and contain cerebrospinal fluid. When infection reaches this space, inflammation occurs, swelling increases, intracranial pressure may rise, and brain function becomes affected. That is why symptoms become severe. Bacterial meningitis is the most serious. Common organisms are Neisseria meningitidis, Streptococcus pneumonia, and Haemophilus influenzae. Bacterial meningitis progresses rapidly and is a medical emergency. Viral meningitis is usually milder. Common causes are enteroviruses and herpes simplex virus. Fungal meningitis is seen in immunocompromised patients, such as those with HIV infection or on long-term steroid use. Risk factors include crowded living conditions, weak immunity, lack of vaccination, a recent ear or sinus infection, or a head injury. Classic symptoms of meningitis are high fever, severe headache, and neck stiffness. This is called the classic triad. Other important symptoms include vomiting, photophobia, altered mental status, irritability, and seizures in severe cases. In infants, a bulging fontanelle, poor feeding, and excessive crying. On examination, a doctor may find neck rigidity, a positive Koenig sign, and a positive Brudzinski sign. These signs increase suspicion of meningeal irritation. Diagnosis starts with step 1, blood tests like CBC, CRP, and blood culture. But blood tests alone cannot confirm meningitis. Step 2 is an imaging test, like a CT scan of the brain. This is done before a lumbar puncture if there are signs of raised intracranial pressure, focal neurological deficit, or altered consciousness to prevent brain herniation risk. Step 3 is the lumbar puncture, the key diagnostic test. It collects cerebrospinal fluid, CSF. In bacterial meningitis, CSF shows high WBCs, neutrophils, high protein, and low glucose. In viral meningitis, there is a lymphocyte predominance, normal or mildly reduced glucose, and mildly elevated protein. CSF examination confirms the type and guides treatment. Bacterial meningitis is a medical emergency. Do not wait for the CSF report if suspicion is high. Start antibiotics immediately. A common first-line regimen includes ceftriaxone plus vancomycin. In elderly or immunocompromised patients, ampicillin is added for listeria coverage. Dexamethasone is given before or with the first antibiotic dose to reduce inflammation and neurological complications. Supportive management includes IV fluids, oxygen support, antipyretics, and seizure control, often with ICU monitoring. Viral meningitis is usually self-limiting and requires supportive care like hydration, rest, and pain control. If herpes is suspected, acyclovir is used. Possible complications include hearing loss, brain damage, sepsis, and shock. Early treatment significantly reduces mortality. Prevention is most important. Vaccines include the meningococcal, pneumococcal, and Hib vaccines. Other measures are early treatment of ear infections, good hygiene, and prophylactic antibiotics for close contacts in meningococcal cases. मैं हूं डॉक्टर अभिषेक। मेनिंगिटिस एक लाइफ थ्रेटनिंग इमरजेंसी हो सकता है। फीवर के साथ सीवियर हेडेक और नेक स्टिफनेस को इग्नोर मत कीजिए। अर्ली डायग्नोसिस और रैपिड ट्रीटमेंट से जान बचाई जा सकती है।